Hi everybody. Let's continue our discussion of extremity trauma from Bailey and Love. Now we come to the treatments of fracture. Treatment of fracture is based on four principles which are reduce, hold, heal and rehabilitate. Reduce, hold, heal and rehabilitate. First we reduce the fracture, then we hold it for sufficient period of time to allow it to heal. Then we rehabilitate the patient by physiotherapy to achieve the maximum functional output, which is our prime goal of fracture management. Fracture can be reduced operatively or non-operatively. In other words, we can reduce a fracture in an open or a closed way. What is an open way? By giving incision, exposing bone and reducing the fracture under direct vision. And what is the closed way? In closed method, we just manipulate the fracture ends to bring them back to their normal position. So no incision and no exposure of fracture ends is needed. An important question is, do we need to reduce all fractures perfectly and anatomically? The answer is no. We only need to reduce intra-articular fractures anatomically, because if we don't restore the smooth joint surface perfectly, with each movement of the joint, there will be friction, and over the period of time, degenerative joint disease will develop. So take home point is, for intra-articular fractures, there should be anatomical reduction. And for extra-articular fractures, only mechanical alignment is needed. I guess you already know what is mechanical axis and what is anatomical axis. Mechanical axis of lower limb is if we draw a line from center of the head of the femur to center of the ankle, it passes through center of the knee. And this relationship should be maintained. For each bone, there is different reduction acceptability criteria. We don't need to go in that detail. Just remember, for extra-articular fractures, we don't need 100% reduction. Mechanical alignment should be restored. In children, there is great potential of remodeling. Hence, greater degree of displacements can be accepted. Open reduction is utilized when we cannot achieve closed reduction. During open reduction, care should be taken not to unduly devitalize the fracture fragments by stripping intact periosteum. As bone feeds through periosteum, stripping the periosteum means to cut off its lifelines and destruction of biological environment, resulting in depletion of healing potential. Now let's discuss the table of benefits and risks of operative treatment. Number 1 is pain relief. If we reduce the fracture, pain will be relieved. Number 2 is prevention of infection. For example, for open fractures, we can debride and wash the wound during operation, reducing the risk of infection. Number 3 is restoration of anatomy. Anatomy gets restored. Number 4 is we can move the limb early if we have reduced and stabilized a fracture. And the patient can also move early in this way. There will be improved functional outcome. There will be reduced risk of secondary osteoarthritis if we anatomically reduce the intra-articular fractures. And patient can return to work early, thereby cutting financial cost. And what are the risks? On top is any complication of anesthesia. Then any iatrogenic introduction of infection. Iatrogenic damage to soft tissues and neurovascular structures can also occur. Bone can become devitalized by soft tissue and periosteal stripping. If we put an implant, there will be need for its removal. Financial cost is increased in terms of expenses borne for treatment. This is an illustrative diagram of manipulation and close reduction of a fracture. This is ground reaction force and this is force of body weight. This is compression surface and this is tension surface. When abnormal force gets applied to distal end, volar surface will fail in tension and dorsal surface periosteal hinge remains intact and fracture ends gets displaced like this. And when this force gets removed, the bones will recoil to bayonet opposition. And this will be the position when patient presents in ER. What we will do now? We will apply a traction and will manipulate the fracture in such a way that first we increase the deformity by pressing upon the distal end to reverse the sequence of injury without tearing or further damaging the soft tissues and periosteum. Now fracture gets reduced and soft tissue hinge is closed with further manipulation. And then a POP cast is applied to hold the fracture with 3-point fixation. Now we come to hold. When fracture ends are in acceptable reduction, they needs to be held for sufficient period of time to allow it to heal. There are various methods to hold a fracture which we will discuss in a moment. No matter which one we choose, our aim should be to optimize the biological and mechanical environment to create the most favorable conditions possible for fracture healing. And we should provide enough stability which allows return to normal function while fracture heals. We can hold a fracture with one of the following methods. Number 1 is by plaster casts or splints. Number 2 by tractions. Number 3 by Kirchner or K-wires. By external fixators. By plates and screws. And by intramedullary nails. Arthroplasty, also called joint replacement, can be used where intra-articular fractures are not reconstructible or its vascularity has been compromised, like displaced intra-articular fractures of neck of femur in older patients. We have already discussed the concept of absolute versus relative stability. For a quick recap, absolute stability is when there is 100% accurate anatomic reduction with compression across the fracture, allowing no micro movements, setting the environment perfect for primary bone healing without callus formation. This method is desirable especially for intra-articular fractures where callus may interfere with joint movements. And relative stability allows micro movements at fracture site, thus callus forms and indirect bone healing occurs. Coming to plaster casts and splints, they are used to hold stable fractures and supplement the fixation of unstable fracture, like we can apply a below elbow cast after K-wire fixation of distal radius fracture to supplement the stability. In this way, we have used a combination of holding methods. Plaster casts come in two forms: plaster of Paris or POP cast and synthetic fiberglass cast. Of them, the POP cast is preferred one in acute settings as it is easier to mold it. In acute cases where there is risk of swelling or compartment syndrome, only back slab can be applied and close clinical observation is mandatory. Now some of the advantages and disadvantages of casting and splitting. Advantages include number one, no wound. As no incision is given, just close manipulation is done. No interference with the fracture site. It is not so expensive and is also adjustable. There is no need for implant removal. Disadvantages include limited access to the soft tissues. For example, once we have applied a cast, we cannot see the condition of the skin or wound unless we remove it. Cast has a weight and is cumbersome, especially for the elderly, and it interferes with function. It has poor mechanical stability and breaks easily upon getting wet. It can cause plaster disease, that's joint stiffness and muscle wasting. Coming to traction, traction is defined as the stretching force on a limb to pull a fracture straight. After appropriate pain control, simply pulling on the limb using manual traction will help realign fracture fragments, returning overall length and alignment. The advantages of traction are more or less the same as for POP cast, including no wound in the zone of injury, no interference with fracture site, cheap and adjustable material. Traction can be static or dynamic, can be skin traction or skeletal traction. It has some unique disadvantages like it restricts patients' mobility to great extent. It proves expensive in a hospital stay. If applied for longer time, longer will be the hospital stay and longer will be the bill. Can cause pressure ulcers or bed sores as patients remain in bed all the time. Can cause pin site infection. As the patient's mobility is compromised, can cause thromboembolic events. Traction is most commonly used for femoral shaft fractures in adults as a temporary measure to comfort and to allow transfer of patient until definitive fixation is done. This is a Thomas splint which is applied initially in a static fashion. The load is applied to the patient through tibial pin via these cords which are tightened with the Spanish windlass technique. The counterforce is applied through pressure by the splint on the ischial tuberosity. When the patient gets shifted to bed, then traction is applied by dynamic system in which the load is applied by weights suspended from the tibial pin and counterforce is the patient's own weight. Now let's proceed to next holding method, the K-wires. K-wires are smooth, non-threaded, thin, flexible wires often between 0.9 and 2.5 mm in diameter. They are used to hold small fragments in place, and they may be used in a temporary fashion intraoperatively to hold fracture fragments in place until definitive fixation with plates and screws can be performed. They are used as a definitive fixation tool around wrist and hand due to their flexible nature. Supplementation with POP is often needed. Summarizing the indications for K-wires, they are used for temporary fixation, as a definitive fixation method for hand and wrist injuries, for tension band wiring of patella, for temporary immobilization of a small joint. Moving on to external fixators. External fixation involves percutaneous placement of metal rods or fine wires into bone to anchor a metal frame on the outside. External fixators can be simple uniplanar with pins and rods for simple open fractures, or it can be a ring fixator, also called Elizarov fixator, after the name of surgeon who invented it, consisting of threaded rods, pins, wires, and rings. Or it can be a hybrid fixator, a combination of ring or simple fixator, and it is a tailored spatial frame for gradual deformity correction. Proceeding to advantages and disadvantages of external fixators, advantages include no interference with fracture site, adjustable after application, soft tissue accessible for plastic surgery. It was the big disadvantage of POP, in which there was limited access to soft tissue. Application of external fixator is quick procedure and a rapid stabilization of fracture can be achieved with it. And it is easy to remove as no anesthesia is usually needed for its removal. Disadvantages include pin site infection. If a heavy busy frame has been applied like an Elizarov fixator, then it can interfere with plastic surgical procedures like skin grafting or flapping. Usually it allows sufficient soft tissue access along with fracture stabilization. It can be cumbersome for patients. Coming to plates and screws, plates can be used when anatomic reduction is required. They allow early mobilization and can provide absolute or relative stability depending upon the fact that they have been used in compression mode or neutralization mode. Disadvantages include the interference of plates and screws with fracture site as they are directly applied on it. Periosteal and soft tissue damage. Does not allow immediate weight bearing. Potential for infection and metalwork complication is there with plates. Will need removal after fracture has healed and got consolidated. Coming to intramedullary nails. IM nails are best suited for diaphyseal fractures where mechanical alignment is required together with relative stability, allowing indirect bone healing. IM nails can be placed in an unreamed or reamed fashion. Reaming is the process whereby the intramedullary canal is widened slightly to allow passage of a larger diameter nail. Advantages of IM nail includes their minimal invasiveness, allow early weight bearing, less periosteal damage than plating where open reduction and internal fixation is done, seldom need removal. Disadvantages are there can be risk of fat emboli with reaming. If gets infected, it becomes difficult to treat due to its location being intramedullary. It becomes very difficult to remove if it gets break. If it gets broken, it becomes very difficult to remove it.